breaking out into groups. We've had a reconsideration of that, given this group and given the room itself. And I think we won't do that. We'll just sort of take questions of all three speakers. And I think knowing you from prior discussion, that could be kind of lively. And if you don't raise your hand, I may call on you anyway. So let's do our usual introductions, and I'll start with myself. Patrick Jones from the University's Public Policy and Economics Institute. I've been with this group since the founding, and it's wonderful to see our evolution. So I'm going to start in the back row, and I forgot your name with the Kurt Williamson, Franklin Community Health. Yeah, please speak up because we have people on the phone. And we'll go across.
Maybe I could help out still on County. Amy Norton, EMC 105.
Oh, great.
FYI, on the phone, we can't hear you.
Yeah, I don't think, those of you on the phone, I don't think you're going to be able to hear these introductions. We'd have to pass a mic around, so just bear with us until we get to you all.
And could you ask people to slow down a little bit, too? We might hear a little bit if people speak slowly.
Okay. So let's go 60 beats a minute, not 120.
Bill Dunwoody, Catholic Clinic. Kyle Sullivan with the Franklin County Department of
Franklin County what?
Department of Human Services.
Human Services. Okay.
Jennifer Wesley, adult drug.
Marshall Pickett, adult drug court.
All right. I guess we'll go with you.
Next row, Susan Campbell, room 60 nursing. 40 wife from Southeast Washington, aging and long-term care. Martha Lemon, Columbia County and Garfield County Public Health Administrator.
Okay, Matt, speak up.
Miguel Messina, Comprehensive Healthcare. Rick George, Comprehensive Healthcare.
Carol Long for Community Health Plan of Washington. Pat Lissay, Community Health Plan of Washington. Teresa Carter, Community Health Plan of Washington. Good morning, Dr. Beavis Lord. Michelle Mann, Columbia Basin College.
Oh, great. Well, welcome. Thank you for hosting us.
You're welcome.
And
Sarah Foster from Australia, to make that helpful. Lisa Hacker from Yakima Neighborhood Health. Jocelyn Pedrosa, Yakima Neighborhood Health. Michelle Sullivan, Yakima Neighborhood Health. Caitlin Stafford with the Mayor Group. Jeremy Snow White with the Mayor Group. Carol Moser, Greater Columbia ACH.
Nancy Campbell, Lutheran Community Services.
Ronnie Bachelor, Lutheran Community Services.
okay.
John Modell, Richmond School District.
Oh, okay.
Terry Williams, Washington State University.
Oh, welcome. First time, I think, right? Okay.
Tom Adams, Chocolate City Behavioral Health.
Chuck Eaton, volunteer with Blue Mountain Heart to Heart.
Kylie Smith, Greater Columbia ACH. Diane ACH. Suzanne Floyd from Healthcare Authority.
West Lucky, Greater Columbia.
Ashley Fernandez, Greater Columbia. Lauren Johnson, Greater Columbia.
Okay, we had the lady in the blue shirt.
Jean Merle.
Who's my group?
Family Learning Center.
Family Learning Center. Anybody else that came in last minute? Okay. So those of you on the line, if you wouldn't mind introducing yourselves, and we'll see how that goes.
Health Center, Washington.
What was that?
Mike
Could you
Maples,
repeat
Community Health Center, Washington.
Okay, next.
Liz Whitaker, Kittitas County Public Health.
Hi, Liz.
Hi.
Hi, this is Gina Manny from PNWU and Community Health of Central Washington.
Okay, welcome.
Good morning. This is Laura Sim from Seattle Children's.
Okay. Could you just do that one more time with Seattle Children?
Laura Sim with Seattle Children's.
Okay, thank you, Laura. Anybody else?
Stillman, University of Washington Center for Health Workforce Studies.
Oh, hi, Sue.
Hi there, there's an echo. I don't know if everybody else hears it, so if there's more speakers.
I think we don't hear the echo, Sue.
Okay, all right, I'll live with it.
Other people mute their phones when they're not in use, so maybe that would help.
Coordinated care.
Okay, let's try that again.
Andrea Davis, coordinated care.
Okay, Andrea.
Hi. Hi there, this is Sheree Robinson with Home and Community Services, Tri-Cities.
That's Sheree?
Yes.
Lutheran Services? Didn't catch that.
It's with Home and Community Services.
All right. Anybody else after Sheree?
Yes. Joyce Newsom, 211.
Great. Good to have 211 here. Anybody?
Brian Sandoval, Yakima Valley Farm.
Yeah, sorry you can't make it. Hopefully you can participate via phone. Anybody else?
Hi, this is Shawnee from Signal Health.
Hi, Shawnee. Anybody else?
Good morning, this is Denise Fergoso with Molina Healthcare.
Hi, Denise. Thank you for checking in. You're making sure that Jorge says the right thing?
Yes.
That's awesome.
Okay. Anybody else?
Dan Ferguson, Valley Health Center of Excellence.
Oh, Dan, we're missing you on the but you got a conference or something, right?
I'm doing a spiel in a few minutes up here in Spokane.
Oh, okay. All right. Anybody else? Okay, so we had a couple more people in the amphitheater here. And Mark, is it Mark? Do you want to introduce yourself?
Yeah, Mark Hawkeye, Providence, Catholic in St. Mary's.
Okay, thank you, Mark. And this gentleman, I don't know you.
Sundown Ranch from Yakima, residential substance use disorder treatment.
Okay, well, welcome. Anybody else? Yes.
Sandy Kuroga with Coordinated Care.
Okay. And somebody else from, is it Yakima Valley Farmers Clinic?
Yeah, Angelina from Yakima Valley Farmers Clinic.
Okay, thanks, Andrea. All right.
Oh,
Sam. Yeah, hi. All right, so the first of the speakers is none other than our own Wes Lucky, and he's.
We're going to go through our report first.
Do we have a report? Oh, yeah. Got to do the formalities.
Right.
Yeah. After the report from Carol, then you'll hear from Wes, and then from me, and then from Suzanne.
So good morning.
Good morning.
How are you all doing? Well, okay. I learned that we went to Pullman, Ruben and I went to Pullman, and we heard from a woman that's doing some instruction, some curriculum at the Sunnyside Elementary School in Pullman, and they're teaching their kids to respond to how are you doing with a hand signal. And I'm not exactly sure how it all goes, but if you do this, it means you're really wigged out. And then the teacher knows if you're wigged out, you're not ready to learn. And it was just so cool. And I was thinking, wouldn't that be nice if we had something similar in our lives so that when we come to work and our boss says, how are you doing? You're going, I am wigged out. And then your boss says, well, why don't you go to Starbucks and have a coffee, you know? Unfortunately, that's not our lives today. But if anybody has any technique for mental health and being prepared at work, let me know, and I can start doing them. All I know is some deep breathing exercises, right? So everybody take a deep breath. Okay, are we ready? So thank you all for coming this morning, especially people that have not been here before. We're just going to run through our report. This is a compilation of things that have happened since our last meeting. We think that we need to highlight some of these activities to keep you in the loop. I use this all the time. I go back to these directors' reports because I forget, some of the things that have happened during the month. And we have a lot going on in our region. And the first thing on the list is the current state assessment. How many of you that filled out LOIs have received your current state assessment? Great. I've been told by Rhonda Huff, make sure you have at least a bottle of wine before you fill it out. She said more like a barrel. I don't know if I would recommend a barrel, but it is lengthy. But this is the requirement of the healthcare authority so that we can get baseline data on your organization. It also tells us if you're willing and ready to enter into a contract with Greater Columbia for the purposes of doing our 4 project areas. It is due by the 31st of May. And it's lengthy. We apologize for that, but it's going to yield us some great data that our practice transformation coaches can use when they go out into your businesses. How many of you are registered in the Washington Financial Executor Portal? All right, congratulations. That is no small task. It has taken Kylie and Diane hours and hours of time working with you individually to get you registered. If you're having difficulty, you can call our staff. They also have some really good details on what to do if you get stuck in this article. We've had several great meetings with congressional delegates, and a lot of this is around opioid use. Dan Newhouse and our representative from Senator Murray's office are really curious about what is our region doing with regard to opioids. Nicole Austin had a great forum through the Benton Franklin County Medical Society the other night. I learned so much. I encourage every single local health improvement network to have a similar forum. And we paired an emergency room director with a sergeant from the Kennewick Drug Task Force. It was enlightening. It was so interesting to see the intersection of what they are facing and the pervasiveness of this epidemic. I had no idea, but it's really, really frightening. Sergeant Jordan said, it's like an ant fighting an elephant. It's like swimming into a tidal wave. And to think that this is such a disabling epidemic to our communities, we really need to get on top of it. I'm sure Nicole would be willing to share you the questions that they asked. They were thoughtfully prepared by members of the Medical Society, and it was just a great turnout. We also have a success story. So Lord Health Network has been going through practice transformation with Sam. They're really excited. They're on board to be integrated by June 11th. All right, great job. Good job. And then the Twins Exchange program kicked off last week in Franklin County. So we've got a lot of really great things going on. The Practice Transformation Work Group, and Mark Wakai is one of our co-leaders, as is Brian Sandoval. They've been working hard to try to shape what this practice transformation looks like to our community, to our region. One of the pieces of their homework is to explore these change categories, and you can see that what came out on top was leadership and collaboration. And this is really necessary. These are really necessary change concepts as we're moving through practice transformation. So a lot of the CSA will be scored based on the selection criteria that the Practice Transformation Work Group came up with. And we thank Mark and Brian for their leadership and all the people. I know Bill Dunwoody, Jorge, Kat, Barbara. There's some other people that are on this team, so we thank you for that service. The DINTI committee, the Data Management and Health Information Exchange Committee, has been working hard, and I think Jorge is the chair of that, along with working with Wes Lucky. They're looking at our health information technology needs and our exchange needs. And when we're looking at practice transformation, we need our providers to have easy access to data. They need to be able to communicate between each other. So this is a really important piece.
Can I interject?
Yes.
You're talking about that, and you say we need providers. We need providers at the table. We need clinical providers, IT personnel who joins us, because we're going to have to try to design something, and without their input, it's not going to be possible. So if you work for a clinical provider, 1 or 2 hours in 2 weeks from your IT people could help us a lot.
Okay. Did you all hear that, providers? Thank you, Jorge. And she is not here yet, but we are so excited that we have hired a practice navigator. Her name is Janet Shelton, and she will be joining us on Monday. So you will see another new face in our office come Monday, and we are so excited to have Janet. Did I leave anything else out? Any other announcements? Okay, well, on.
Wait a minute, Carol. You went over a lot of stuff real quick, so before you leave the stage, are there any quick questions?
The world is.
There's a lot going on. If you're not really up to the daily flow, it could be a little overwhelming. So, any quick questions of points 1 through 9?
You can always call us. We have a great website. All right.
Okay, thank you.
Wes, you're up.
So, Wes is now going to take the stage, and I think you'll find his comments at the very minimum very interesting, if not more than interesting, a bit provocative. He's worked pretty hard on this presentation, and going to give you his take of the workforce needs, the workforce preparation as we currently know it in the state of Washington. So, Wes, I hope you can do this in 20 minutes or 25 minutes. But,
we'll try to get through this. Can everybody hear me? I'm going to let Lauren make a quick announcement here for something that came through our shop.
So Bethany contacted us, and she wants us to announce that the Ben Franklin Health District will be hosting a grant writing class May 31st through June 1st. And you can find their information on our website. We actually have it on our calendar section. So if you go to May 31st, you'll see all the information there, and then you can click on the link and register if you'd like.
Thank you, Lauren. So as Patrick talked about, this is an interesting presentation. Much of it is borrowed from another presentation that Dan Ferguson, who's not here, was on the phone, provided to me. It talks about healthcare workforce, which is one of the domain 1 subject areas. This is a really important part of transformation work. So we want to highlight that it comes from this particular presentation. So we're going to start out by looking at the familiar Christmas tree. Hopefully this is a real Christmas tree, and Santa will leave us lots of financial presents. It's important to look at this. The other day, our team looked at the Christmas tree and the measures on here, and we came to the conclusion, and I think this is pretty obvious, but most of these measures, as much as 80% or more, are tied to access to care. Access to care, either to primary care or to behavioral health. Now, part of that can be addressed through scheduling needs or changes to scheduling, but a lot of it comes through transformation of workforce. Workforce is essential. In the ideal world, I remember years ago when I worked for Group Health, Milliman did a lot of work with us, and they came up with actuarial models around primary care, and they said in the ideal primary care setting, in a community that's focused on primary care, as much as 85 to 90% of visits, office visits, should be going to primary care. So most of the individual's healthcare needs should be delivered through primary care, not urgent care, not the emergency department, not consultants or specialists, but through primary care, 85 to 90%. In the real world, their analysis showed that less than 50% is. Individuals self-refer out again to some of those settings, and they receive less than optimal care. So given the fact, the dilemma that we should face now with shortages of primary care, behavioral health, oral health, and other providers, addressing workforce is going to be essential. More of the same in health professions, education, and practice will have significant negative consequences on population, health, and costs. This is a very provocative statement. And it doesn't mean that schools like WSU School of Medicine, which Dr. Williams is working on here locally, are doing a bad job, or CB School of Nursing is doing a bad job. They're doing an excellent job at turning out excellent clinicians. The issue is that the nature of healthcare is changing. And that means individuals will have to come together through interprofessional teams. They may have to expand or change their roles, and new individuals and new roles will have to come online. So this comes from some research from the collaborative from which we've pulled this information, and it talks about current workforce planning approaches which may not fit the purpose of meeting our future challenges, which is the transformation of care or practice. I'm not going to go through all of these, but some of the highlights is that current professional training is focused less on population or health service perspective and more on the professional perspective. Limited definition of what the healthcare workforce actually should look like. Not used to redesign. It's not used to redesign workforce, workflows, and care delivery models to better meet patient needs. Some other issues, again, this comes from the collaborative. It's less productive in the past. Part of that is because so much time is spent on administration with managed care and insurance. Too many workers not practicing anywhere near the top of scope of practice or top of their license. State laws in the state of Washington and other states have something to do with that. Poorly distributed against need. For example, there's shortages, a lot of shortages in rural areas. Provider shortages in some of the areas we talked about around primary care, oral health, and behavioral health. All of this makes this non-sustainable. This is the key framing question. To move toward developing the modern healthcare workforce, we must ask this. What are patients' needs for care, and how might health professional roles, regulation, education, and practice be redesigned to meet those needs? So this comes from some things that we've talked about in the past. In the upper left, you'll see the major causes of death per thousand for this country in 1900 and in 2010, so 110 years difference. You'll see that the death rate has dropped by almost half. And I know you can't see up there because it's so small, but the major causes of death at the early part of the last century were mostly infectious disease: diphtheria, tuberculosis, malaria, GI infections, pneumonia, and the rest. We've done a great job in dealing with those through antibiotics and other treatments. Well, those are beginning to fail a little bit, which is another discussion. However, the major causes of death now tend to be more towards chronic illness. More towards chronic illness, heart disease, diabetes, COPD, and the rest. This requires new approaches to care, a focus on wellness and prevention, and greater patient engagement. It also means focusing on high-cost patients. As we'll see in the next slide, Healthcare Authority is making a decided move towards value-based payment, which includes pay for performance, bundled payment episodes, capitation, and a lot of other arrangements that put financial risk on providers for cost, quality, and more. So with that, providers need to strategically focus on those high-cost, high-risk patients. Again, in a previous presentation that we've given, it shows that 5% of any normal population accrues about 50% of the costs. 5% accrue about 50% of the costs. So to be effective, we have to identify those individuals. And again, value-based payment will accelerate this shift. However, lack of attention to workforce may be a large reason that new care delivery and payment models, for example, value-based payment, are not showing expected outcomes. This is the framework that Healthcare Authority has put together. By 2021, which is 3 years from now, they expect 90% of providers to be on value-based payment arrangements. So how do we envision the workforce needed? This comes from New Zealand, and what they're looking at is strangely similar to what we're looking at. They're facing a doubling of demand, primarily because of an expanding population and an aging population. They're putting a greater focus on population health while maintaining or improving both patient and provider satisfaction with only a 15% increase in funding. Think about that. That's a huge ask. Under old workforce models, they've worked to retrofit care delivery models to meet the competencies and roles of the existing workforce. Under the new model that we hope to encourage, it'll require outside-the-box thinking about what care pathways and the resulting workforce should look like. So what that means is focusing on the needs of the patient, the population, and the community, and fitting the workforce to those specific needs. These are some framing questions and ideas that have come up, again, in the presentation that we pulled from rather than focusing on workforce shortages such as RNs, doctors, how can we move more effectively and efficiently deploy the workforce already employed in healthcare system on interprofessional teams? So if we have a shortage of workers, the prevailing narrative focuses on shortages, but maybe many, if not all, shortages might be addressed by reallocating tasks among providers. We need to empower teams of licensed and unlicensed providers to reallocate workflows and redesign care pathways. There also needs to be a focus on needed skills and training shortages as well. I'm going to run through these fairly quickly here. Under the next reframing, rather than focusing on provider type, instead recognize the plasticity of provider roles. So under the old school, it assumes professions and specialties have fixed and unique scopes of practice. Under the new school, we recognize this idea of plasticity of role of the real world practice. Professions and specialties have overlapping and dynamic scopes of practice. So future workforce will need to be highly flexible. It also encourages practicing to the fullest scope of practice or top of license. Plasticity recognizes that roles will dynamically change depending on patients' need for services, the setting, and the availability of other providers. Instead of retrofitting care models to meet existing competencies of the workforce, we need to ask, what are patients' needs for services? How might health professional roles be redesigned to meet those needs? This is a list that I think a lot of us have seen at least some of these names. These are new emerging roles to the workforce: patient navigators, case managers, care coordinators. Community health workers is a topic that's been discussed a lot within this group and among the project teams. Department of Health has held trainings here, and we have trained community health workers in the community, like Ronnie Batchelor here in the audience. All these will be essential. However, they may not necessarily be new roles. They may be roles that overlap on existing roles, such as got some echo there. Such as overlapping over nursing, EMS, social workers, counselors, and more. This is interesting. In New Zealand, they train postal workers to stop by individuals with certain chronic health conditions to see how they're doing, to see if they're following their medication. Very progressive. It's a great idea. Here, we have organizations, for example, like Meals on Wheels, who could potentially have a role in that as well. We've talked about the community paramedicine model as well for individuals who do EMS and downtime. Might have a role in this too. It's important to consider that many of these roles play a hand in transitions of care between one setting and the other. This is a lot of times where we see care, as I call it, fall over a cliff. An individual transitions from primary care to specialty care or rehabilitation, and they either never make it there or they never make it back to primary care. Facilitating those transitions and helping patients through that process is essential for care coordination and success under this model. It also shows that it helps reduce admissions, it lowers costs, and it helps increase patient satisfaction. Another idea is this idea of what's called boundary spanning roles, which are growing. A couple of examples here are panel managers who assume responsibility for patients between visits. They use EHRs, patient registries, identify and contact patients with care needs. This could be part of the job of a medical assistant, a nurse, or other staff member. There are also health coaches. I've actually seen a couple of these here locally who improve patient knowledge about disease, medication. They promote healthy behavior. They help patients get active and stay active. One study that I saw that out of all chronic diseases, not one specific disease, but out of all chronic disease, the two single biggest risk factors are inactivity and obesity. Inactivity and obesity. A lot of the chronic conditions that are challenging us relate to lifestyle. The third reframe relates to silo-based workforce planning for individual professions. Rather than focusing on workforce planning for professions, instead do workforce planning for patients, people, families, and communities. So this talks about expanding workforce planning to include workers in a broad range of healthcare, community, and home-based settings. This might even include community-based organizations. An example is given here of social workers who traditionally might focus on behavioral health consulting. They may also act as care managers, and they may also have a hand in managing referrals, not only to other providers, but also to community-based organizations to address the social determinants of health. So in terms of redesigning the structure to support new roles through practice, there's a need to minimize role confusion by clearly defining competencies and then training for those new functions. Job descriptions may have to be rewritten or newly created, and workflows may have to be redesigned. This is not without pain points or challenges. Some of these challenges include a lack of standardized training and funds to support this sort of work, existing staff who may not delegate or share roles if they don't trust that other members are competent enough to fulfill those roles. There's also the issue of time spent in doing this change, which takes away from billable services. The workforce innovations needed to implement practice transformation, I've inserted that terminology here, require an adaptable regulatory system capable of evolving with the healthcare environment. The health profession regulation system in place today does not have the flexibility to support change. So in part, what's needed here to support regulatory and policy change is to understand how effective are these new models in terms of controlling costs, increasing quality, and increasing satisfaction. By doing that, we can create evidence-based models that help with policy reform. So here's a summary list of ideas that I'm going to walk through here pretty quickly. First, transfer of the workforce and service delivery from the ground up rather than the top down. That means focusing on patient needs, community needs, and population needs, and building the workforce around that. Design ideal patient pathways by service area. Identify education, regulatory, and practice changes needed to support new models of care. Also, make it personal. How does it affect Aunt Susie who has dementia? We need to engage coalitions of the willing. That's a term that came from President Bush during the Iraq War, to overcome professional resistance and possible tribalism. Develop care coordination competencies across the workforce and incorporate technology into workflows. It also means increasing supply of health professionals with generalist skills. These individuals might be more adaptable to this idea of plasticity that we talked about. Also, diffuse experience, moving from acute care settings to a focus on outpatient community-based settings, such as mental health, primary care, geriatrics, perhaps rehabilitation, and more. modify education and regulation to allow task shifting between health professionals and expand roles for the existing workforce. So for example, dental hygienists in the state, if they practice through the DHAT program on tribal reservations, can fulfill roles that normally they can't practice outside of that. Address training needs of unlicensed health professionals, for example, community health workers. And finally, better integrate healthcare and community-based workforce to address the social determinants of health. That's a lot to contemplate. You guys are all very quiet. Does anybody have any questions about that particular slideshow? I know it's a bit.
So yeah, let's take a bunch of questions here before we lose some of the detail in Wes's presentation. When I read this morning before I left Spokane, I called it the manifesto by Wes Lucky. He's out there sort of in front of the institutions of healthcare, beating on the door. So maybe you have some comments whether that beating on the door is appropriate or not. So, Suzanne.
A comment or question. I do believe in the role of technology, the changes coming with technology in healthcare will really impact the workforce, as well as when we started this discussion about access. You mentioned about the issues of access to care. So I guess I didn't see as much emphasis on the flexibility needed to quickly incorporate the technology that will help with the workforce issue. And I just want to make sure that it's on the table and that we are watchful of things that we can incorporate in our community that will help deal with access. And I'm going to give you one example I watched recently. Was a program that allows parents of high-risk infants that have been released from NIC settings to input data on up to, they can do it on an hourly basis, but they're inputting data on a tablet of their neonates, of their newborn health status. And using the algorithm that's provided, the subtle changes that are within that run outside those parameters that could lead to a potential needing to go back to be readmitted can be alerted to a health professional quickly. So here we harness the power of the technology, moving the infant outside of the high acute setting and allow them to be within their home, but still having access to a provider. So to recap, I really believe that making sure that we're nimble enough on the issues of workforce to quickly incorporate healthcare technology that will allow us to increase access.
I think that's a great observation, and clearly we could spend an entire presentation, if not a day or more, talking about technology in terms of the work that we're looking at doing. I know Sam comes with a sharp eye towards the need for, when we talk about practice transformation, it's not just systems and processes, but it's the overarching technology that goes into everyday practice, which includes things such as patient registries around chronic disease, risk stratification to identify that top 5%, producing quality metrics, doing data analytics, and a lot of other work. Also, patient engagement, as you talked about, with the mother with the discharged NICU baby, having patients become engaged in their care and the care that they're overseeing is essential. I think we have to be careful about that last piece because there are different levels, and how do I say this, of your social demographic status can affect your ability to access that. If you don't have the income to have a nice computer with a high-speed bandwidth connection at home, it makes it difficult to access that. You may not even have a smartphone. You may have a flip phone. If you have a phone at all, although I have to say everybody has a phone now. You may be homeless, but you're going to have a phone. But the ability to access that based on your cognitive ability poses some challenges for individuals. So I think that to facilitate that long list of new healthcare roles, I think individuals there can help out with that. But certainly technology is a key part of that. And it's something that the GME committee is working with Jorge and the rest. But the organization is talking about constantly how to make this work through new technologies, health information exchanges, population health management. Again, we could go on and talking about that.
So I really appreciate you mentioning health coaches and the variety of folks that can be included in their health coaches. That conversation happens right now. The ones that are owned locally or elsewhere are being paid for out of pocket by those of me. Because there's not a way to really incorporate it well and get it covered. So, you know, there's promising practices, but it needs to be on the forefront. We're going to encourage lifestyle and behavior changes. The other thing was looking at what you're talking about with the variety requires a lot of delegation within roles, which means those at the higher levels of license and practice end up bearing a lot of that responsibility. So conversations about liability and what that might mean and how to protect folks in that has to be a part of the conversation. And to the first slide, just a reminder that you're doing this single payer healthcare system. So, you know, there are those things that you have to think about when you're trying to reduce that kind of influence, that kind of change.
Good observation.
I just had a question. We have it on the website.
The slideshow? Yes, everything that, we'll go through 3 slideshows today and PowerPoint, a little bit of PowerPoint fade towards the end, but all these will be made available on the GCACH website with all our past meeting materials. We've created a great website where this information will be accessible to everybody, and we're also recording too. We're also recording the presentation if you want to go back and listen to it again. Thank you.
So on the lines of reimbursement, if you talk about, I love that talking about redesigning the care for what the patients want, but I hear repeatedly in the quality officer from complaints that I don't want to do a wellness visit, then a chronic disease management visit, then this kind of visit. I'm one person and I want to address all of my needs in one visit. So how can we get reimbursed for that though? We can't get reimbursed for that type of care. So,
Suzanne?
So I have some plan colleagues in the room who might be able to help comment on this, but I'm going to speak from a healthcare authority perspective. These are all good questions to think about, and thinking about them in the framework of the world we have, which reimburses those privileges by behind people who can only do certain things. What I would encourage you to do as you think about your workforce, financing is an element of how you successfully embed and take your workforce forward. So it's a great question. Wow. I would encourage you to think about value-based payments. And I would encourage you to think about, as we grow value-based payments, how do we address things like, how do we get credit for a visit? That includes multiple aspects. What's the right way to value a visit? How do we code that? That's going to require partnerships with us as a healthcare authority and your planners. But what I want you to think about is how you use value-based payments to break up your team's infrastructure in a way that takes us forward to look at a team and a rate of service. Rather than, can my community health worker get paid $75 a visit for going out, and my healthcare get paid $25? That'll be elements of what we do when we get down in the midst of how we pay. But thinking about your team and who you need to deploy will help us think about what's the total cost of care that you're delivering inside your system, and how do you allocate that out to effectively deploy the resources you have to meet your needs. That's a pitch for thinking about how we do this from a value-based perspective.
So I'm going to ask Sam, do you have anything you want to follow up on that? Because she has, about tools around that. Is there anything you want to add to that in terms of reimbursement?
No, I think that she has wonderful job setting that up, and moving forward, I think that we really have to look at reimbursement and value-based medicine, because I have done that before, and I've seen this efficient $25,000 to $50,000 checks reimbursed just because they really got into it and actually looking at the population, managing the so it really is rewarding. I know it's scary at first, and rewards don't come until later, but during that transition period, really, you kind of manage, just making sure that you're managing your patients safely. I promise.
So under these new models, there are possibilities of having reimbursement that have traditionally not been billed for. Corey?
From the client perspective, and what I hear in the field is, you talk about the teaming in the medical system, I think that's great, but our clients also have teams. And if we don't change the traditional medical primary care situation so that that loving daughter who works full-time Monday through Friday cannot go to those visits with neighbor or their, whoever their these informal support people who can help ensure, because we know that 80% of what happens in the home, not in the doctor's office. So you have to have the client's teams with them, and that's impossible when the last appointment of the day is 3 o'clock. It's impossible when we aren't open on Saturdays only for triage care. Because and I have seen us change a little bit, and I think we should advertise. There are some clinics that are open till say 7, but there's a perception, although none that I can, or my family, but there is a perception too that that's only triage, whether it is or it isn't, I'm not gonna judge, but I do think we have to consider our clients' families or their informal support as part of their team, and they can't get to appointments Monday through Friday, 8 to 5. We have to look at that differently if we're going to see higher engagement, more of that ongoing following doctor orders, especially when we're looking at the growing numbers of memory. You need that client. We're going to have to.
Hi.
So the primary care medical home has to adjust to meet the needs of the patients based on what their needs are. The traditional 8 to 5, 9 to 5 model may not be convenient for them, which limits their ability to interact with the healthcare system.
Yes. Hi.
Somebody on the question?
Yes, this is Gina Manny from Central Washington Family Medicine and PNWU. And I am very excited to be involved in this phone call. I'm going to talk slow because of the echo. Carmen Mendez invited me to this, and I didn't know that it existed. But at Community Health of Central Washington, we recently have created a population health department, which is addressing exactly those needs that you're discussing and talking about new innovative billing strategies and outreach to reach the patients that are not able to come in the 8 to 5 general region, including home care, group care visits, etc. In the future, I will email you all and reach out and make sure that I include the director of our population health, who's really working and addressing on care gaps in quality care, and we're also tracking outcomes with this. So I think that would be a lot of valuable information for this group.
Thank you. There was a comment on the feed that from Dr. Kevin Martin, who corrected me. The model of postal workers actually came from the UK and Jersey. So I apologize, I got my countries confused.
I kept waiting for you to say that providers should look those that they serve and sound like those that they serve, and wondered whether you were going to get to the reverse. And that is that the populations which can get to providers tend to look like the providers that exist now. And those that don't look and sound like the providers that exist now don't get services.
So I think that relates to the issue of cultural competency across race, ethnicity, and perhaps other socio-demographic groups. I know that the community health centers, the FQHCs, have tried to address that through either bilingual providers or providers that meet the nationalities that they serve. But certainly in this area where we receive people from Burma, Somalia, other African countries, not to mention Central and South American countries, that can be a challenge. That can be a challenge. It's a good observation. Ronnie?
There's also consideration as well as low income. Personally, I agree with microaggressions and prejudice. Differences in treatment of when they see me coming through the door and I have a Medicaid card, I'm treated differently. There's these microaggressions that occur, but then when they find out my history, they find out where I'm at, where I work, and all these other things, and all of a sudden the quality of care goes up. And it's been an ongoing experience, whether I was working or not working, because I've been up and down that valley. But it is
definitely there, it's definitely real, I'm not imagining it, and when I call them on it, no, we apologize for that. Well, if they're doing it to me, they're doing it to others. And I see the same thing within ethnic groups, because I do come from a home with this multicultural. And when I see them treat me different with my sibling next to me that happens to be a different color or skin tone, it really becomes bothersome. And hearing the horrific stories from them about how they've been treated within the medical system of care, they treat them as if I have a niece that has narcolepsy. And the doctor wouldn't diagnose, the doctor wouldn't even look at narcolepsy because of her age. But in true fact, she is, and it took 5 specialists to find out what was really happening with her. And my sister being treated like it was discounted all the way through, you know, regardless of what her education level is.
So the idea of bias,
Higher educated.
the idea of bias and prejudice in healthcare is real. Miguel, you shot your hand up. Did you want to follow up on that?
Yes, but I want to go back to Mr. Chuck. I think I'm trying to pretend that I read his mind, but one of the things that we get often confused is just sort of the cultural competencies of practicing medicine or practicing counseling versus the social biases that our systems are embedded into. So what Mr. Chuck meant to say is, for example, my own dentist, they open, 9 to 5, right? So I happen to be a middle-class person with a professional job, an insurance card, and benefits in a work setting that I can say, I will leave early today because I have a doctor's appointment. And nobody in my agency will question that because I have the freedom to go back to work later if I overdo stuff, or I can go back to work tomorrow early and whatever. Or simply I'm cut out of my day, I'm leaving early today to go to a doctor's appointment. I will get that 3/4 of our population don't have the luxury. But you have to be in the jobs, you have to be in the farms, you have to be in the job sites, you have to be in the warehouses, you have to be where the jobs are, and you have to be working. So if somebody works out of an area because they're in a job site, in construction, it's impossible to tell the foreman, I'm going to be gone for 2 hours because I have to go to a dental appointment. The response will be like, okay, you go to the dental appointment and don't come back tomorrow. So those are the second layer of our cultural framework that often gets swept under the fact, am I bilingual or not? That is a concern, nevertheless, but we miss a lot of great opportunities to just take good care of our clientele just because we set our practice for a middle-class projection.
Think about benefits coordinators, they'll go into the hospital or go to the schools and they'll come sell you your insurance or your investment planning, but we don't do any medical benefits like that. We don't go show up and let them have appointments right at their work site.
Right. That's great. Miguel, that's a great observation. There's a recent book that just came out, the name escapes me, but it talks about how a lot of what ails us is based not only in the flexibility of the employer, but it's caused by the employer. Stress levels in this country have gone up for decades. It's no secret, and that in part has driven part of the opioid crisis and part of the rise in suicides. So something has to give in that arena. Angelina has had her hand up for the last couple of questions. I want to call on her.
I do have a question, but just to comment on what everyone's saying, I did see an article recently that talks about how in the U.S. we value stress. We value that like high impact job, and it's a cultural thing, so we need to consider that as part of the population health. One of the things about value-based payment that I think of that relates to what a lot of people have been saying about really putting ourselves in the consumer perspective is value-based payment seems to be it's like diagnostic accuracy and treatment, but then cost. I try to think of it cost to whom? Cost to me as a provider, cost to the payer, and then one of the biggest factors I think is we're reshifting and having this time and a waiver is the cost to the consumer. And I think that can sum up a lot of what we're talking about, like if they can't pick off work, because it's hourly, if they can't get in, if we need to go to where their families are and stuff like that. So when I see a lot of stuff about the cost, I always try to keep that piece in mind almost at the forefront. What's the cost to them? So maybe that's another way to reframe it when we're having talks about PVP. My question about the presentation was the plasticity that you mentioned. Have you seen some of that integrate into the training programs that are out there? Because it's true. It's in the real world when we're on the ground. You really do have to have that fluid conduit ability to go across, and I was just wondering if in your research or discussion, if you've seen some of that stuff.
Let me pose that to Susan, Dr. Williams, John Lovedell, and others who are involved in the training piece. Have any of you seen any of that? The plasticity of roles.
I can certainly speak for the CBC's nursing program with the RN bachelors. We do incorporate more of the need for that flexibility of the role of the nurse, not just an acute care shift work, but that opening, that expanding what the role of the nurse in the community for primary health, health and wellness. So, yeah, I think it's a good point. I guess there's always a need, I guess, within a profession to cover a certain amount of content as a required component, but in the context of community.
I understood that plasticity was more about a site nurse being able to provide medical care and for able to provide, emergency room care. Even though that I understand I'm supportive of nurses' roles, educators and leaders and the contracting and so on and so forth. But I misunderstood, I'm not sure. The professional plasticity has to do much like, for example, the clinical training. At some point, it has to be able to deal with more than one issue. And the person has to be able to address chemical dependency, has to be able to address mental health, family relations, social environment, and provide an array of diverse counseling modalities and skill set that helps individuals within their context, rather than diverse professional roles. Because I don't think, in my mind, was speak of plasticity if a nurse is trained, let's say, in emergency room care, but then they decide to become a health educator working in a university. It speaks of their own individual professional plasticity, but not to the practice of that.
I think Carla has a tag on to that, and I'm going to choose you after that. Carla, go ahead.
Just a kind of a question about what you're talking about is that the specialty-driven medical profession that's occurred over the last 2 decades, where we've moved away from general practice and primary care, which is what we're talking about, like where the need is, and that medical students are like, no, I need to go, I have to have specialty. I'm not going to be a regular doctor. And that's a big, we've got 3 decades of specialists in medical care that are not necessarily.
You had a question?
Yes. Well, I'm from GCACH in Othello. We have one in Long Island, Walloop. Kind of going back to access, we've changed our clinic hours from 7 to 7, 5 days a week. And that's been huge for our patients because we have most of our patients are farm workers or underserved communities. We also changed our pharmacy hours to 8:30 on Thursdays. We also deliver medication. We have smart cards that do that. Again, we're not a big hospital setting for a rural community health center. And one thing with integration too, we have our pods in our new campus in Othello. We have 3 pods. They're set up identically. So we have MAs, providers, health educators, and behavioral health specialists. They can grab, hey, I have a question, grab them. We also have a mental health ARNP on campus that they can also refer.
That's great. We're going to cut off the questions for right now. I know that there are more to go, but we have 2 more presentations, and I don't want to suck all the oxygen out of the room from your responses. I think up next we're going to have Patrick present us with a little bit of data, and then we're going to follow on with Suzanne, who has, she and Patrick will work with a set of questions. Thank you.
Okay. So this will not be nearly as provocative as what you just heard. This is a compilation of 2 reports, and I am the messenger of both of them. But I hope you do have some questions. So this is, I think a few of you know, I'm an economist, and there is actually a bit of effort by economists in the state of Washington to try to look out into the future about workforce needs. And any of you who have college-age, high school-age children, you may want to consult some of this because they really do, I think, a pretty decent job of saying, this is where the job market of the future in the state of Washington is. So I have used, in the first instance, the reports, the most recent report which comes from 2017 from the Employment Security Department, just for one part of our region, Benton Franklin counties. I was looking for Yakima as well. They didn't break out Yakima as a county, so I'd have to ask them to do a special cut of the data to look at Yakima. And they didn't do Walla Walla for those of you from Walla Walla. So, but we do have a particular focus available on the Tri-Cities MSA. So I'm going to talk about this a little bit, and then I'm going to just double back to the survey that I think many of you know about that was conducted about a year and a half ago by my shop, looking at organizational needs in the Greater Columbia ACH. And I'm going to just home in on the workforce questions. There's just 2 or 3. So that's really the substance of what I'm going to say. And I will tell you the punchline when you compare the report from The Economist and Olympia to what our organizations actually reported as their needs for workforce, there's a contrast. And so maybe that will evoke some comments from you about who is correct. So a little bit about methodology. This is what is called a midterm forecast. It's based on a big database that is maintained by the Bureau of Labor Statistics and in the state of Washington by Employment Security. And we're going to look at the annual average openings for the years 2020 through 2025. That's kind of the midterm forecast. And there's 3 different ways of looking at this. And I'm focusing on the most conservative set of numbers that consists of 2 parts. The new jobs that will be out there due to industry growth, which is actually modeled by a national model. And then the replacement of those who leave the occupation and not replaced. So that's what, and there's a couple other approaches. So this will deliver the lowest numbers. And importantly, I'm not going to go through this, but if you just look at that top bullet, the assumption behind these economists is that the current labor force mix is going to exist in the future. And if you just heard from Wes, and you believe what Wes is predicting or asking for, this is not true. Because we see probably the delivery of care, an office visit, say, is actually shifting considerably from what it was 5 years ago to what it will be 5 years in the future. So, but that's really all that economists have to go on. They have to make simplifying assumptions. And if Wes could tell me, you know, a new office visit is going to have 1/10 of a doctor's time and physician's time, and 3/10 of a nurse practitioner's time, and 5/10 or 4/10 of a nurse's time, and 1/10 of a nursing assistant, then they'd be able to model that. But you know, nobody knows. This is all in flux about how healthcare is going to evolve. So what you're going to see in the numbers I'm going to show you is saying the future is like the past, which is a little misleading. Okay, so within that outlook for 900 plus different occupations, there are, I don't know, 100 that I would say are healthcare professions. So I've tried to group these into 5 different groups: physicians and dentists, mid-levels, behavioral specialists and community-based specialists, support staff, and what are known as technicians in the occupational language. I'm just going to show you just quickly some graphs then for the average annual openings for the Tri-Cities from 2020 through 2025. And normally when I present graphs, I would change the horizontal axis so that you wouldn't have these little stubby lines and they'd look a little bigger. But I'm trying to make everything consistent with these 5 different groups, and you'll see in a moment why I chose to have this, in this case, the maximum value go all the way to 100. So this is looking at sort of the top of the hierarchy in healthcare delivery, and the average annual opening forecasted for the Tri-Cities. For internal medicine, at the bottom is 1 per year. For family docs is actually 2 per year. And I looked at that and I said, I don't know if I believe this. But then I thought, okay, so what's the panel size of a doctor these days, of a general practitioner? Anybody want to tell me what sort of a fully loaded is not the right word, but a complete panel size for a GP or an internal medicine?
10 years ago, it was about 2,250 to 2,500 people per provider. Karen, you probably have updated it more.
It's about 2,000.
That's what I was going to say, about 2,000. So if you look at that, there's between, at an annual basis, an internal physician, an internal doc, and a family practice doc. There's 3 doctors times 2,000. That's 6,000 patients. And the Tri-Cities hasn't been growing that fast. Tri-Cities has been growing about 3,000 per year. So, you know, it kind of does make sense that there would be this low number of demanded for primary care folks. And with respect to what Carla was just saying, the top line really, the top bar really refers to specialists. And so that's the demand for specialists in the Tri-Cities, 20 per year. And that's, you know, everything but PCPs. Okay, now let's go on to the mid-levels. According to this forecast, same scale, look at the top bar there. This is what's being forecasted is nursing. I don't think that comes as any surprise to people in this room, but you know, in contrast to family docs of let's say 2 or 3, there's almost 90 that has been forecasted to be demanded per year.
Can you go back to your previous slide just for a second? So I don't see any behavioral health counselors for.
That's coming. That's coming. Okay, so I'm just taking this in groups.
Sorry.
So if you look at the mid-levels, you know, nurse practitioners, annual average demand is maybe 5 or 6, physical therapists a little more, and all the way down. So the real story here is obviously nursing. Okay, now to your question, Wes, behavioral health and community-based specialists, and this is where I think you know, the model gets it wrong because things are evolving pretty fast in our mix of healthcare delivery. But you can see at the top the number 1 forecasted occupation in this area is social workers. Community health workers, in contrast, there's which is a relatively new occupation. I was surprised they're even tracking it. Is 1. Where?
Let me talk with Mike. Yeah.
There we go. Yeah, that's 1. So you know, this is just, I take this with a grain of salt, but think about the think about the orders of magnitude here between what you're seeing on the different slides. Oh, Kevin, do you have a question?
Okay.
Yes. Do those projection numbers take retirement into account?
They do.
So that separates growth from projected need. As the workforce ages out, you would expect to need more providers than just to account for growth.
Right. Yeah. If you go back to one of those slides, Kevin, it's projected growth plus people leaving the occupation due to whatever, but in many cases that's going to be retirement.
I believe someone on the phone needs to put their phone on mute, please.
Please. Okay. So let's keep on going. Same scale. This is support staff, and if we're talking about this team approach to care, I think some of this is captured by the economists at ESD. So leaving the first bar aside, we're looking at health aides, annual average openings in the Tri-Cities being in the 50s, and you see nursing assistants, medical assistants, dental assistants, all of some significance. Okay, so again, think about this as a pyramid, and so these professions or these occupations are actually projected to be pretty numerous. And so my question is, what's training involved? Are we training enough of them? How are they trained? And then finally, just looking at technicians, And they group dental hygienists here. They, for some reason, have LPNs in here. But you can see the other categories: radiology, lab techs, diagnostic sonographers, and the like. Fairly low numbers for technicians. But you add this all up, and there's a little shy of 100, and you can see, if I could put them all on one slide, what the relative dimensions might be of the different occupations. Okay, so just to try to summarize this, here's what I got out of the forecast. A pretty low demand for primary care providers, a very high demand for nurses, a low demand for all other mid-levels, and this is surprising to me, a relatively low demand for behavioral specialists, which I think we might be able to contest, and you're going to see it in some different form here in just a sec. Relatively high demand for assistants and aides, and then a relatively low demand for technicians. So that's the crystal ball that the forecasting group in Olympia has come up with for the Tri-Cities. Okay, now let's switch gears and talk about what you said. There's about 40 organizations that responded to this survey in February of last year, and this is what you replied with, and saying, to the question of what is your organization's greatest need? And you could answer more than once. And you see here, it's quite a bit different from what we saw from ESD. Mental health counselors leads the array. Other behavioral health workers is second. Psychiatrists and psychologists is third. So I think we get the drift here pretty quickly. This is quite a bit different from what we saw from ESD. Primary care providers, number 4, nurses, number 5, and so on. So that's what you're saying. These are the occupations that currently have the greatest need. And then we asked the question, once the demonstration project is sort of going in your organization, whatever that may be, whatever the demonstration project is, then where do you forecast or where do you foresee the greatest need? And here we have, again, a similar story: mental health counselors, behavioral workers, psychiatrists and psychologists, primary care doctors, and nurses. So pretty consistent with what is today and what you envision might be in the future. So, before I start just wrapping up here and contrasting this, we did ask some open-ended questions about what are the biggest barriers for your workforce. Thought we might want to review these for you. The first, the most frequent one was difficulty in recruiting and retaining. And there's lots of reasons for that, but a couple of the reasons that were mentioned more than once are quality of life issues and then spousal opportunities. So that was the most common one. Basically, the other one was the cost of care in rural settings and allowing from reimbursements and allowing payment to healthcare professionals. And then the third most frequent comment was generally the low production of primary care providers and other behavioral health specialists from our institutions. There's just not a lot of people coming out that are looking for jobs. And then the final one was and there were more, but in terms of frequency, the absence of residency slots in the 9-county area. Okay, so those were the open-ended questions, and I think it's a pretty decent summary of the greatest barriers that to a healthcare workforce working in, being able to optimize the organization's mission. Okay, so just some real quick wrap-up thoughts. I do want to point out, there's a difference here in how this was conducted. One was a survey with an N, or a response of only 40. I don't know what the universe is, but I'm sure it's 2 to 3 times that much. So whether this is representative or not, I don't know. And ESD, of course, is using not a survey, but administrative records from their huge database. So as an economist, we like administrative records wherever possible because they're usually pretty accurate. Surveys have, especially with small samples, have pretty wide margins of error. So just a couple of questions for me and perhaps for you. Is there a difference in workforce needs between those organizations that primarily serve Medicaid and those that serve all payers? Any thoughts on that? For those of you who are in either category?
Not really.
Not really?
I don't think so. The workforce needs doesn't change. We've taken Medicaid and in the past with the implementation of the GCACH, but the workforce needs haven't changed.
Okay. So, did everyone hear that? Is that Liz?
Yes. This is Gina Manny, and I actually would disagree because in our lower SES group, there are often a lot more comorbid conditions. So I think the approach and the amount of external resources, including behavioral health providers, is a little bit different in the Medicaid type of patient group.
Okay, so two opposing views on that. Any other quick comments?
Well, Dr. Jones, I think, I don't know necessarily how it influenced the workforce. I think it influenced the workforce in the available pool, making a selection to which environments to go work to.
Okay.
And I think that is maybe a change in the discourse. Traditionally, primary community mental health centers are training grounds. People come with, a lot of cysts and vision, and they work maybe their first 5 to 10 years of their careers, and then they move on to something that maybe is more steady or less convoluted, or they seek some other specializations, or, and it's, the truth of the matter is that it's taxing. I mean, community mental health is very hard. It's a lot of comorbid. There's a lot of things that get in the way of practicing your craft. So at some point, I think it's just a natural progression. People lose a little bit of the kind of the fighting spirit, and maybe you want to go to environments where practicing your craft is a little more easy. It's a little more, 9 to 5, weekends off, and those kind of things. So I think that the population itself and the payers, what they do is just influence where the professionals move to their continuums. Which some of us have been always a tremendous advocate of our own continuum to continue to promote salaries and healthier environments for people to remain in our environments longer in their professional lifespan. I don't know if that helps the information some, but that's my perspective.
So just to clarify, Miguel, so in the end, you think there is a bit of a difference between, say, an organization like yours and an organization that treats all payers?
Well, certainly,
from all payers.
I mean, a lot of folks come to our regions to work because the programs and the opportunities to pay for their tuition reimbursement and so forth. Also, they come to our programs in the central of the state because they're great training grounds for training and development. Once, you have mitigated some of your school expenses, or once you have gone through those 5 years or 10 years and you consider yourself an expert in your field, people have the tendency to move to other playgrounds.
Okay. This gentleman, then Ronnie.
Well, just to echo what this gentleman is saying, I think that because of the economy of Medicaid reimbursement, the way that agencies generally manage that is and the Medicaid population complexity of issues that they present, we give the least experienced and the least skilled therapists the most complicated patient population to treat, which creates problems for both sides. Students that want to get out of that service area as fast as they can because it's overwhelming, and plus that the population of service providers are changing like a carousel. Medicaid recipients and people who come to our services often complain that they never get to know a therapist longer than 6 weeks, or they never know who they're going to see when they finally come in for services. So a trusting relationship to deal with those issues is difficult to form. And for the providers, they're generally overwhelmed by the issues that they're seeing. And they don't they don't imagine themselves trying to create a career of serving this population. So they're trying to migrate out of that as quickly as possible. And that's primarily a way of managing the economy of serving a Medicaid population.
Okay.
My experience has been totally different. The observation I've seen over the last few years is that organization signs, say, gets grant money or signs a contract for a large capitated amount of money, and then I've seen the professionals follow the money, regardless of the funding source or the population that they're serving. So the danger here, as we're talking about workforce development, is that the same group of people are just kind of moving around following the money and the contracts and the grants, but there's no influx of new professionals. So we're not really creating access. We're just creating more access to organization A because they got a new grant, and those counselors went over there. And then organization B now has 10 less counselors or professionals, so they don't have as much access. So the access is just kind of the same. The professionals move around and follow the money.
Okay. Good point.
One observation.
Is that Kevin?
Yeah, just in terms of methodology, looking at Benton Franklin, I don't know that that's generalizable to the rest of the region. In terms of workforce here in Kittitas, we have about 17 primary care FTE for a population of 45,000. So if you assume a panel of about 2K, we're at least 5 FTE shy before we get started. All of the county is a HRSA healthcare provider shortage area, and I suspect that most of the other rural areas in the region are shortage areas as well. And I believe
I think it's very true that urban areas are definitely more populated with physicians than rural areas. So, okay, Ronnie, and then I'm gonna leave the stage.
This is Brian. Can you hear me okay?
Yeah, go ahead, Brian.
Real quick question. If you go back to the last slide with the workforce, or one more back, when you have the numbers at the bottom, is that the number of clinics or 0 to 5, 10, 15? Can you talk about what that is?
It reflects the number of organizations that responded to that particular question, saying, in this case, mental health counselors are our greatest need. That would be 22 organizations said that, Brian.
Got it. Thank you.
You bet. There's another question?
From Liz on this slide.
Okay, what's the
Is this
question?
slide limited to the Tri-Cities area, or does it cover all of?
So Liz, this is only about the Tri-Cities. That's the only tab on the spreadsheet that I could get clean data for, and I'd have to do a special cut to get data for, say, Kittitas or Yakima or Walla Walla and any of the other counties in our ACH. So that's the answer. Ronnie.
Some of the challenges that I've seen on the ground are make an appointment and having the consistency of care on when the population doesn't have enough PCC to deal with really hard health issues. A lot of times there's not that consistency available for the patient, and then they're declined because they've missed more appointments, 3 appointments they missed. They have to come in as a walk-in basis because of the quantity of people that are coming through the door. I don't know if this is those 2 guys or not, but the challenges around that also involve the community health worker role. That there's a lot of community health workers here that are trained that are looking for employment but can't find employment, and they have the ability to do the outreach and to be able to see the client that didn't make it. And the sad thing is that with the quantity of populace that's being seen, they get to pick and choose who they want to see and who they want to deal with on a daily. But when you have those comorbid, issues happening in patients, oh no, here comes X again. But if they're on the phone trying to make an appointment, there's no appointment available except for 3 months out, and their health determinant right now is emergent, so they end up in emergency room. So there's really a high need all the way around. When you have a well-rounded service, I'm very fortunate. I've been able to create a relationship with my doctor. When I started seeing him, I was not employed. I really had questions in the beginning if I wanted to have a relationship with him. But I made it a point. I need to have a relationship with my doctor so you know what's happening with me. I know when something's wrong, I can get in to see you. And he's made that available after we had this maybe probably 7 hours of counseling. But not all doctors are going to give you that. You know, I'm just very fortunate, and I've just seen some really harsh things out there. And there are people dying in the streets because they can't get in to see a doctor because either the doctor is choosing, you know, or the office is saying, you know, and it's not said out loud, but it's like, no, we don't have any appointments except for X, and that's 3 months down the line. And they only get basic care when they go to the emergency room or they go to, if they go to urgent care. So.
Well, I think we've heard that from a couple other speakers, just the issues with these kind of settings. So thanks for making that personal. All right, so I'm gonna turn it over to our third speaker, and Suzanne Swatner, is that how you pronounce it? Sounds like a good German name. Swatner. And she comes to us from the Healthcare Authority, and if you can read her bio here, a lot of things have happened in her life before the Healthcare Authority. So she's going to talk to us about the issues that we're seeing in workforce in the ACH from the perspective of the HCA. And there'll be a bunch of questions that she will walk us through at the end of her presentation. So Suzanne, the floor is yours.
Okay, thank you. Can you hear me okay, or should I use the microphone?
I use the microphone.
Can you hear me now?
Much better.
I'm going to talk to you today a little bit about the Sentinel Network to start with. My colleague Sue Skillman, who is a researcher and a workforce data expert at the University of Washington, worked with our colleagues at the Health Workforce Council and some other team members to come up with this tool. This tool is a demand-based workforce projection tool. It gives you information about what is happening in the ACHs and across the state with regard to what types of professions have need and demand from an employer perspective, what gaps people are seeing in their access, and gives you good information about what's happening in the community. I'll then transition to talking to you a little bit about some planning we were doing for having conversations, either in small groups or as a group, about what these workforce competencies and skills are that we might need to build for you, what you need in your team to make your work alive. Workforce for us as a Domain 1 entity, as in the Medicaid Transformation Project, has a broad scope and incorporates the strong work that Sam will be doing with herself and her new navigator to work on practice transformation and moving our practices to patient-centered medical homes and giving them lots of great tools to manage that and to understand how their practice links to value-based payment. Workforce also entails some of the data issues that Patrick just presented to us. And workforce then entails what do we need to put together the workforce of the future on the ground? How many of what do we need where? But most importantly, what are, for now, in the transformation project, we have a total of a 5-year window to make a difference. So working with our colleagues that we've heard from in the nursing program and in the medical school program, we can't train our way out of this. We can't train our way into new workers and really address particularly the significant gaps in skilled professional competencies, training, and access. So what we need to do is to work carefully together with all of our incumbent workers in all of our settings to identify the skills and competencies they need to move to population-based, whole person-centered integrated care. And that's the focus of the questions you'll hear later. When I look at what my role is at the state, my role is to assist and support the ACHs in identifying their needs, bringing them together to find common needs so they can put shared resources together to address training, to address workforce gaps, to think about innovative new models, to put people like Sam together with their colleagues to say, what are you learning over there? That's a cool idea. Can I do it here? I also will work on, and working on putting together a team to look at what kinds of state-focused levers can we pull to support the great comments we've had about financing and how financing influences our workforce capabilities and competencies in our models. What kinds of tools do we need on the regulatory end so our licensing standards allow the flexibility and boundary spanning? Do we need new tools? Do we need to interpret them differently? What does that look like? So I'm looking forward to working with folks like that across the board. We're also working with our education providers across the state to work together with them on the hard work they're doing to integrate these population-based health and boundary expanding activities into their curricula. As they said, it takes a little while to make that happen. And so our goal is to figure out what the right partnerships are and the right players are to put them in a room together and figure out how to take curricula to the next level. So, I need technology training.
There you go.
So the Sentinel Network, this is a quick snapshot. And Sue, are you there on the phone?
I am here.
Great. Do you want to introduce yourself to the team now that I've talked about you?
Sure. I'm the Deputy Director of the Center for Health Workforce Studies at the University of Washington. We're one of 7 health workforce research centers with core funding from HRSA, along with some of the slides you saw earlier in Wes's presentation were from my colleague, Erin Freyer at the University of North Carolina's Health Workforce Research Center, I'll just add. And I'm also a researcher with the Rural Health Research Center here and a few other things.
And we're fortunate to have her to support us in our work. The Sentinel Network is an information network linking healthcare industry with partners in education, training, policymakers, and workforce planning to do some look. As Patrick indicated, most of our data around workforce is supply-based data. How many of who do we have where? The Sentinel Network is geared towards saying, how many of what do we need? Do we have the right set of skills from those people, and where do they need to be? Who do we need where? The focus is to identify and respond to new and changing demands for healthcare workers' skills and roles through this survey. So do you want to talk for a moment about how you started this work and where we've gotten to now?
Sure, and I think that this was a great setup with our other speakers because historically the labor statistics that, like Patrick showed, point to very occupation, head count, looking to the past, not where the industry is going to the future. And the message that's often delivered with those kinds of labor statistics are, oh, how much do we need to turn up the spigot at the education systems to produce more of X, Y, or Z? But we recognize that as healthcare undergoes this massive transformation, it isn't simply about turning out more at the education institution. So you also saw that the labor statistics are often inaccurate on the ground. That was a national model. That's not taking into account what's going on in Washington State. And, you know, we can go on that, but it's useful. These are very important bits of data to take into account when you're putting together all those bits of information for planning. But what we saw there was a need for was a tool to get signals from employers, the industry, as we undergo healthcare transformation. What is the impact on the workforce and employers' needs? The workforce is not just those folks who are coming out of institutions, or sorry, coming out of education institutions. We have a huge incumbent workforce, and as we undergo transformation, we need people to be taking on new roles or slightly different roles. They're going to need new skills. We need signals. We need messages, we felt, to clue us in everyone involved in health workforce planning and policy to understand where those needs were. Not just how many more headcounts, how many more to turn up the spigot for, but what are we doing across the system? What are the skills needs? What are the roles changes, et cetera? So this is the first of its kind venture into being a sort of a mouthpiece for employers to give us those signals around roles, skills, and types of occupations where change in demand is happening. And the diagram you're looking at there, that's kind of the left side providing data into this data hub. And I always call this a data mediated information system to connect up the industry, the healthcare delivery on the ground, communicate workforce needs to those who all can help respond to those needs. As we go through this, it isn't that it provides every answer, but it gives the signals about changes in health workforce, or it's designed to provide the signals of changes in health workforce needs in the state, in a region. I'll stop there.
Can you talk for a moment about who a Sentinel is and where this information comes from?
Sure, and some of the people in the room may be Sentinels. We so far have had 4 time places where we had a website where employers could come and provide their data. Data is requested. When you go there, if you're an employer, you say, what kind of facilities do you operate? You know, hospital, large or small, FQHC, behavioral, mental health clinic, et cetera. Then we ask, what kind of occupations do you employ? And then it drives people to as short as possible of a list of questions that solicits information, a lot of qualitative information about which occupations are experiencing changes in the demand, which occupations are experiencing in those facility types, different skills needed, different roles that they're taking on, and then that's provided, that's made available on a dashboard, and then we're we've prepared to date a few summaries of the kind of information we are getting. But one of the key things here is it isn't just about the occupations. It's all that comment information, the qualitative information that goes with it, where you as employers are saying, we have exceptionally long vacancies for registered nurses, and part of it is because we aren't keeping up with competitively with salaries. There's more, you know, whatever those reasons are, that's a lot of the valuable information we're trying to collect.
So this, I've taken you to the live website for the Sentinel Network. I did not put this in my presentation, but I will give it to the team to make sure that you have it. Feel free to go in and play with it. It's kind of interesting to move around and find things that are generic, that are not just generic, but specifically relevant to your needs. This is a summary of the findings overall. At the state level, it's separated out by occupation type. So Sue referenced RNs, and we'll talk about that since that, for us, that's a very significant area of need. This lets you know how many folks responded and where from, what kinds of occupations have particularly long vacancies, and that's typically more than 90 days. Is that correct, Sue?
Yeah, in the last 3 to 4 months. Oh, it's up to interpretation. We're trying not to be really quantitative. We're trying to get those signals from employers, but not a high degree of precise quantitative information. Can you go to the map? Can you go to the findings by geographic region, and we could walk them through a couple?
Great, that was my next step. Thanks.
Not that. Go up to findings above. That one, yes. And then the purple box. And then go to vacancies, the blue box over, well, okay, that's fine. Now click on Greater Columbia, the orange part of the map. And then under data collection period, why don't you just pick the top one, this 2017, the most recent one. Okay, so this is saying, if I may be so bold as to take over here, this is saying that in our last data collection period, sentinels from Greater Columbia, of whom there were 27, and they were made up of, this does not show, but they were made up of 7 were community health clinics, and 3 mental health substance use clinics, 3 home health, 3 skilled nursing, and then a smattering of some other facility types. So the most frequently, if you'll hover over the registered nurse orange bar now, okay, so that indicates that 9 of the 27 sentinels reported registered nurses as experiencing exceptionally long vacancies. If you'll click on that bar now, that will give you the reasons why those sentinels said there were vacancies. So if you hover over any one of those cells on that top bar, not enough. Okay, so that's one of the comments. Shortage of nurses, clients do not get all the hours met. Hover over another piece there. Workforce does not demand. So you can see that you can get to all the actual qualitative comments. We've provided a little bit of coding by those different the different bars there, but you can see what everyone had to say. Same thing as if you were to go click on medical assistance over on the left, then you could see, and then go back over and hover over the comments on the right. You can start seeing what folks say about why there's long vacancies. So this is just a little bit of a flavor of what Sentinel Network, the dashboard, can give you. But we also have questions about skills needed and for which occupations and what kinds of skills that needed, what kind of new roles occupations are taking on. If you keep scrolling down, Suzanne, we can look at the skills. Training priorities, there we go, that's the one. That was the one.
Click back on the orange. And then go back over in the most recent period in 2017. Perfect.
And then click on your registered nurse bar there, or any occupation, I don't care. And so up on the top, the new age EHR, so EHR skills were among those needed. So I think you can see that there's a lot of information here. It's a tool that is more useful the more input is provided. And as you are working on transformation of the healthcare in the state and in the region, the goal of the Sentinel Network is to provide feedback as to how that transformation is having an influence, or if it's having an influence, in our healthcare setting. When we start seeing a lot of comments about we need more behavioral health skills in our primary care clinic staff, you're getting a signal that you're getting some traction there. We're starting to get more integration, et cetera. I'm going to stop talking and see what else you want to add.
From the perspective of what we do to support domain and support all of you in planning, both as an ACH, as a group of types of providers, or in your clinic yourself, so you can see how you're measuring up to your colleagues and your other entities with the same type. What it gives you is real-time evaluation data to see how you're doing, see if the changes you're making are making an impact over time, to see if you are needing to change something about what you are doing, and how does this data measure up to the workforce data that Patrick gives us to say, we have a shortage and we need to scratch our heads a little bit, and all of you have great information about what you're experiencing, but this is a way to sum up what everybody said among the HR folks who answered these surveys, or anyone who answered this survey. And is what I'm experiencing the same as what other people are experiencing, or do I need to be looking for something else for the future? The other thing this does is you can look at what's happening in other areas that are like you. You could look at similar ACHs. So, for example, do I want to look at Better Health Together in Spokane and see what's happening there? Do I want to look at what's happening in North Central, because they're a lot more like us because they're rural? And you can see if there are commonalities. Part of my interest in thinking about how to do statewide support is how we have the ACHs use this as a tool to do that kind of work. What are we seeing together that leads us to common sets of shared needs that we can pool resources to think about how to use our practice transformation specialists in an effective way. Are there resources they could bring to practices? Are there training we need to work together with our education institutions to provide, whether it's academic full curriculum or whether it's new kinds of certificates or on-the-ground certificates? Could we partner with folks like Mark Wakine and his great work in the Providence Health System to say, what kind of training do you guys have? Where are you finding resources? What could we do together? So that's the kind of innovation we're hoping to foster in providing support to you so that you're working together to address community need rather than individually to go, crap, I don't have enough Medicaid money this month. So that's a little snapshot of the Sentinel Network. Sue, do you want to have any closing remarks about where we're going? The Sentinel, I'll give an introduction to that. The Sentinel Network was originally funded through Healthier Washington with a grant called the SIM grant. It was our original founding grant that helped us get the ACHs up off the ground and get them working. The funding for the Sentinel Network, unfortunately, at the federal level, ran out in the end of January. Our governor was smart enough to go ahead and fund a year to give the Sentinel Network and our Health Workforce Council, which is an entity that is part of the Workforce Training and Education Coordinating Board, some money to fund a sustainability plan. And it's a plan not only to track, is this the right tool? Is it doing the right things? Do we need to make any tweaks or changes? As well as where do we find funding to sustain this work over time so we can do the great evaluation work and sharing of resources that we talked about. Sue can talk to you for a moment about some work she's doing to tweak the survey and to make sure that what we are asking of you is the right questions and the questions and information that you can use to make this useful to you.
Right. We just had a steering committee meeting yesterday, and if anyone wants to join the steering committee, let me know. And so we expect we'll have our next opportunity to submit the data, to bring Sentinels to the system, probably later this summer. You will definitely be hearing about it. The more employers, the more industry you can help encourage to put data into this system, the more valuable it's going to be to you. It's, again, we're talking signals here. We've never designed this as being an absolute, totally representative survey. Nonetheless, the more folks, the more employers that are providing information, the more it can be like that. So that means, and then we should be able to do at least one more data collection before our funding ends, current funding ends at the end of June 2019. Then the test will be, is this useful? Is it something that can be sustained or is want to sustain? And we'll see comes to the table for that. But right now we're in a very formative place where to make it useful to you, speak up, take a look at this, see what else is needed or what questions you have, because the whole point is to make it useful. I will say that Connecticut is moving ahead. They've liked this. They've reached out to us and said, can you help us implement this in Connecticut? One of the workforce development regions of Northern California has done the same thing. Utah is moving forward on this, and a few other states have been making inquiries. So this is a model that seems to have some face validity, and we want to keep tweaking it and making it as valuable as possible. Again, to provide the information that classic labor statistics just can't do in a rapidly changing environment that healthcare is in right now. We need skills, we need roles, we need more information than classic labor statistics.
So Carol has a question and comment, and then I'll open it up to some questions.
So, Sue, I was just wondering, and Suzanne, we talked earlier about the need for new roles, new skills, and yet I'm seeing traditional roles being displayed on this map. Is the Sentinel Network also supplying some job descriptions of some of these new roles that we're trying to implement through practice transformation?
We are asking about traditional roles because that's still who you. I mean, there's another question that specifically asks about, do you have any new roles or new jobs that you're employing? So there's a separate question about that. But equally important are, how are you using your existing workforce in new ways, and what different skills do they need? Because still most healthcare delivery is going to take place with the workforce that we have had and so, but they need new skills to some extent, or where we want to pick that up through the Sentinel Network. Tell us how this is playing out. But there is a separate question about new jobs or new occupations. Does that answer your question?
Yes, it did, thank you. In terms of partnering across the ACHs and within your entity, across yourselves, the thing I think about that accommodates Carol's question nicely is, once we get this information, how do we assemble it and put it to use for you? And then how do we establish new opportunities and new ways to share information like this for evolving roles, so we could perhaps, let's assume the world goes beautifully according to plan and we get 5 more years of funding for the Sentinel Network. How could we take the work that we're doing to build new roles and new opportunities and new ways of thinking about hiring and training and recruitment and retention into the Sentinel Network? That's sort of how I envision it. It would happen through a coalition of the ACHs and talking to them about how they want to share that information. It would also happen talking with all of you as healthcare providers, behavioral health providers, but community-based providers, which will be important for the future. How do we put that together in a way that's useful for you? Again, this is an evaluation and planning mechanism. Other questions? Yes.
Hi, 2 comments. One, I guess personally, I see the registered nursing so high because it is such a flexible role within the environment needs. But one of the things I've been kind of interested in for years is the role of a volunteer, and as we move to retiring bolus of people. Is there any way to capture in a system like this, or have you discussed anything about the role of the retired volunteer? I know there's a program for insurance for retired volunteers, but
that is truly a fabulous question, and it's fabulous because you're thinking ahead to what all of us. I'm not as young as I'd like you to think I am, and I'm a nurse by background. When I retire in 20 years, I wish a lot less than that. How could I use those skills to best effect? Do I need to have a paid job, or could I use them in some other way? I think that's an important piece, and I think that that's a good part to think about in workforce planning. And I'm going to flag it in my head. I'm going to tap my brain to remember to talk to you about if we know there are resources. Again, Ferguson might be able to help us. But I think that that's a great idea to think about how we track that and how we help not manage it for communities, but help communities manage it effectively themselves, track it and engage it. Kat, like she has a question.
Just a comment, actually. There's an organization called Maven that actually leverages those retired individuals, and they provide telemedicine support as well. So Community Health Plan of Washington has a partnership with Maven. We'd be happy to share more about that and think about ways that it can be broader than that partnership with the MW as well.
Thank you, Kat. That's really a great opportunity to talk to each other and build on that.
Kat, did you see the name of that organization?
Maven.
Maven.
Yes, and I have to look up, it is an acronym, of course, and I would just have to look up exactly what it is.
And it sounds like we have a few resources to share, including the Sentinel Network after this meeting, and we'll make sure that that gets into the bucket, because that question and that idea of, again, it's being creative as a community. How do we address needs? What could I do with my training as a retiree when I'm really young? So let's go ahead and go back to my slide set. The remainder of, in your slide set, you're going to see a few of the screenshots just of that initial shot. It's just, this is simply intended to let you know the kinds of questions you could do. When I knew we were going to go live, I didn't want to burden you with slides with lots of boxes and colors on them. I just wanted you to see what was available to you. The smartest thing I could have done would have been put a link in there, so we'll make sure you get that. So I have some busy slides here, and these are intended to take us to our next conversation, which is to talk a little bit about, originally we were intending to organize ourselves to talk about potentially small groups and opportunities to brainstorm how in small groups you would begin to do some planning for boundary spanning and competencies and skills that go with the new roles that exist. So these very wordy questions, which are reframing many of the same things you heard from Wes earlier. So lots of smart people think the same, including all of you. The idea here is to take a look at, within your system, what do you need to support moving to transformation? And it's very focused on inside your system, inside your team. A lot of the questions that are there are intended to do that. In your packet is also a thing called the discussion guide. What the intent of doing this is to give you some framework. At this point, what would be good to think, for me to think about with you is how you could use these to have conversations with your clinics and your teams to begin thinking with Sam's partnership, because these questions are going to be very similar to the kinds of things she and her navigator are thinking about. What are the questions I need to ask to build out workforce in the non-traditional way of thinking about that? And that is, how do we focus on our incumbent workers? Because building the skills and competencies of our incumbent workers is what's going to help us transform our system. How do we maximize and optimize the scope of practice? And I'm going to talk about an RN for a second, because I can think about them easily. How do we take an RN in a practice from doing wound care and injections and IV medications and make he or she the leader of a team that looks at population-based health reports and plans out for the 2 weeks or the month what patients need care, when did they last get care, when do they need care again, how do we get them scheduled now, how do we get work they need done in their team before they get to me so I don't have to wait a week for labs and everything to come back in, how do we actively manage our patients, do we need to engage our behavioral health team during the visit that we schedule so that we have someone available to provide care, how do we really do care management. So the things we'll need to think about is what is the roles that are needed in your practice to really support that work. The MA can do a tremendous amount of work for you. That RNs, diligent, do-good souls that we are, do everything. How do we not do everything, and how do we manage a team, and what do we need from our team to do that work? Social workers in a behavioral health clinic or licensed mental health counselors can fulfill the same idea. But that's the idea is, how do you think differently about what your team does? One of the things that I think about with this that's important, and I put it as the very last bullet, but it's not the last bullet for me as an overarching thing to think about throughout this. It's easy to think about how I reorganize work into process flows. It's easy to make a list of the readings I need to do and the didactic I need to go get online in order to get my care management training. It's harder to think about how I manage taking somebody from a role they've done for a long time and that they're very comfortable in and move them into a different role, especially when I'm doing a whole darn practice like that. So one of the overarching things that I want folks to think about as we go through these questions and opportunities is, what change management structures, support, training do you need to make this effective in your practice? How do you build that in? Sam's team has a lot of ideas about that. She can do a great job of working with you, but that idea of change management is important, especially since I know practices go through change management all the time. So how do we take all the time and make it feel less like this is just another thing I'm being asked to do, and make it, this is a new way for me to think about being as valuable as I can for my patients and really focusing on what my patients need to get the care they need when they have it. Another piece to think about here, and I'm thinking about my colleague from Martin Hand and my community health worker colleague, what new roles do you need in your clinics? How do you engage with community health workers from community-based organizations who are actively doing work? What kinds of new partnerships do you need to build and manage care across those continuums? So you're not just simply, as Wes illustrated earlier, dropping a patient over here and waiting for them to come back. What's your practice's role in understanding what happens when they get there and how they come back? What structures do you need to do that? Who do you need to partner with to make that happen? How do you engage those partner organizations in your planning? This was really busy. This we talked a little bit about. What you're going to want to think about is doing your reforming is, and again, Sam's team's going to do a great job of helping you with this, is identifying what are those core patient pathways that meet the needs of that, not only the high-cost people that Wes talked about, but those people who you're watching and waiting because you don't know darn well they're going to get sick. It's just when. And much of the focus we do in clinical care is on that 50%, those high-cost people, and for very good reasons, because they do have high sets of needs, but we also want to think about in doing your risk stratification and doing your prioritization. How do you build pathways and processes for care that support the watching and waiting as well as the access needs? And do you have people in your practice who can help with folks who just need well child visits, folks who need regular checkups, folks who need just a check back a month later for their wound care and make sure it's done? How do you stratify your care? And what pathways and roles and responsibilities do you need? Built into that, I think clinically is the question of, again, skills and competencies. What clinical skills and competencies do you need to change your role and practice in a new role? The biggest one that I can think about is thinking about the project 2A, with integrated physical health into behavioral health or integrated behavioral health into physical health. What clinical skills do clinicians need to adopt those new skills? In a physical health practice, your behavioral health skills are limited. And they're limited because you have lots of physical health things you're doing with your patients and you typically refer. What are the clinical skills you need to screen, effectively manage, and treat the population that you're going to serve in your practice? And how do you get good pathways set up to manage across pathways where needed? The same could happen in the flip reverse for a mental health practice. So what I'm thinking about when I talk to you is how Sam can help you in planning for what ideal patient pathways do you have to support your target population? What clinical skills do you have? What's the right way to get them clinical skills? Is it using resources that Sam has available through her resources? Is it working inside your communities to get my colleagues at the nursing program at Columbia Basin College to build you a care management certificate? Is it working with the medical school to get some core curricula developed for your physicians around medication-assisted treatment? Is such a great example of this. There are a lot of great programs that have come to people and really done a good job here. Are there opportunities like that? Next slide. Next slide. And then I want to focus for a second on that bottom bullet here, because we're getting close to time, and I want to just talk really quickly about a place that we will work together with you to consider how we build structures of support, and that is around regulation and accreditation and other kinds of standards that the state can help you support you, or that the state has primary responsibility for. Licensing standards. What's the role of the community health worker? What's their training like? What do they need to practice their optimum? What kinds of regulations do we need for, as we talked about, boundary spanning and task shifting? What I'm thinking about is the building of a structure to support the ACHs and thinking about issues around funding and reimbursement and how we put a lot of resources together to lever the system effectively so that there's one voice speaking for a broad perspective rather than single voices knocking at a door. So we will be continuing to work on how we partner with our colleagues at the Department of Health who are eager to work with us on this question of licensure. Our colleagues at GCACH, which is quickly becoming part of HCA in about another month or so. And those licensing, there will be some functions at GCACH that will be absorbed to the Healthcare Authority. The licensing functions will be deployed into the Department of Health. How do we partner with all three of those entities to address the issues you have? We know there's some issues, for example, around practice requirements and supervision requirements from mental health providers that are resulting in some ability to train and get folks out in a timely way. How do we address some of those kinds of questions? So that's a place where I am working on how to do partnerships with your ACH executive directors, and that will roll down to you to say, what do you need? What kinds of regulations pose barriers for you? Where are there gaps that don't allow you to do the things you do? What are the things that are going well that you want to continue?
This is Ann. I know that I went to a meeting last night with the Franklin Community Health Alliance, and this conversation, I'm glad Dr. Griffin is here and Kirk is here, came up about this regulatory requirement of licensing and internships. And so if I don't know as much about it as Tom and Kirk did, so and Sarah also has some really great news, because we know that clinical hours, Susan Campbell is always hammering about the lack of clinical hours that are available in our community, and it is a barrier for our medical students if they can't get those clinical hours.
Right.
Could you guys kind of recap what the highlights of what we talked about last night in terms of what might be coming up in terms of licensing a facility as opposed to a doctor to allow that kind of internship training to happen?
Sure. We're at the United Healthcare and MCOs, we're looking at value contracting as an opportunity to kind of look at these new workforce, right? do licensing credentialing more at a practice level rather than an individual level, and how as we move forward through C and the project here, how can we use that value-based contracting to allow for things that haven't been done before, as well as the advocacy that we provide at the state level to make those policy changes.
And that's a great example of what we would not think of as a traditional partnership, but where we should be working effectively together, which is when there's a set of common needs that affect your ability to do delivery of service, that affect your ability to shape a workforce. Our MPOs are good partners, and we want to work effectively with them to understand what their perspectives are, how it impacts them in the work that they do, and make sure that we build solutions that address all needs across the spectrum.
We're drafting a letter to our congressional representatives and our two U.S. senators regarding what's called the Mental Health Access Improvement Act of 2017, and we'll be happy to share that. It's not quite in final form, but basically it says about 2/3 of our mid-level providers in Benton and Franklin counties are not able to bill Medicare, and we think that ought to be fixed, which will help do two things. It will improve access, obviously, but it will also result in some cost savings to Medicare because it will allow mid-levels to work to the level of their licensure and not require an MD or PhD level intervention.
That's great. That's a really great opportunity because you guys worked together and there may be opportunities to gather support more broadly. So thank you for letting us know, and we'll track what you're doing and make sure that if we can partner and talk together about how that's going.
For a buck.
For a buck? $1. Any other questions? And that's how you can find me, at least virtually. Anytime you're in Olympia, I sit at my desk and I'm happy to talk to you. So I'm going to close now by asking if there are other questions, and I want to give Carolyn Western to explain how we want to spend our last few moments thinking about what comes next. Yes, thank you.
I just want to make sure that I appreciated the questions that I would want to bring up with my staff and really drive some of our strategic planning. I want to make sure that this is going to be accessible on the website. Yes. Great.
There are two pieces, one of which is this, and then there's a more dense, comprehensive version of 3 pages of questions. Again, none of these are intended to be a checklist, meaning you have to ask all these questions to get to the answer. There's some guides for you to guide your thinking and think and target what you need to know to address your specific interests.
Tommy should do the next day or two. Okay, that's right.
Thank you very much for having me.
So we're a little ahead of schedule. So Carol and Wes, do you want to wrap up here? Do you have anything specific you want to bring before the group on workforce?
How are y'all doing? That's a lot of information. We originally had wanted to break out into our project team. So we have 4 project areas: bidirectional, opioid, chronic disease, and transitional care. To go through that very set of questions that Suzanne brought us, it's just a difficult room and environment to do that. And so you will be seeing these same questions in your project team. So our next goal then is that we have to get the project teams together. And we're thinking about doing that for June because our mid-year report is due July 31st, and we need some feedback from the project teams on some of these questions. So our goal between now and our next meeting in June, I think it's June 21st, solstice, is to bring the project teams back together so that we can address some of these questions. Otherwise, I think, for the majority of you that stayed today and bared with us, thank you so much. I think some exciting things are happening in our region. I think a lot of this team-based care is here. We're hearing lots of examples. And so our goal is to find out where those innovations are happening and spread and scale them throughout the region.
so that we can all benefit from these innovative practices that we're hearing about, because our region is ripe with them. We just might not know about what's happening, you know, the telehealth things and the consistent care and the care teams. And, you know, we have a lot of stuff going on. We just need to pull it together. So I thank you for your attendance today, for coming. We'll see you next month, but between now and then, we'll have all of these PowerPoints listed on our website so you can access them, along with the list of questions that you might want to take back to your practices. But
so just one more friendly reminder for all of you that belong to organizations that submitted an LOI, you've received that current state assessment that Carol talked about at the very beginning of the meeting. It's really, really essential that we get that back by the due date, which is the 31st of this month, which is 2 weeks, I think, from Tuesday. Again, the information from that will go into this mid-year report. We have two big deliverables, one at the end of July, one at the end of September. The information from that current state assessment goes into the July report, so we need time to aggregate, analyze, and do more with that data. So please, if your organization has not completed it, please complete it. And as we've talked about, there's a reward tied to it as well.
and more than a bottle of wine.
Thank you all very much.
Thank you.